determinants of health. And that's why GHEP has made it its mission to address the social determinants of health, creating programs that directly impact, change, mitigate one of the social determinants of health. The Public Health program, Public Health 360 program is a unique program, right? Since we have started, we have trained nearly 100 Public Health 360 fellows of all backgrounds from all parts of the world. And these are individuals who are trained intensively, unconsciously, and really, really very rigorously that they will go out to change the trajectory of population health across the world. So one of the things we do is that fellows are admitted into a 3-month intensive program during which they learn the nuts and bolts of becoming public health practitioners. They are no longer all talk, right? In public health, one of the criticisms we get is that we are all talk. We talk with no action. But these individuals are trained to become not only talkers, but they are actually providing action addressing specific global health programs. So today, I'm so excited. We have 3 groups, and each of these groups bring unique value to the table. We're going to have the first group is going to be talking to us about a new program that they have designed to address sickle cell disease in the Democratic Republic of the Congo in Africa. And then the second group is going to be talking to us about a program that is faith-based, community-based, that they are going to use to address autism spectrum disorders in North Carolina here in the United States. And then our beautiful third group is going to be talking to us about the really increasing prevalence of drug use and what can be done in a program in Nigeria, Africa's most populated country in the world. So I am excited today. Today I get to sit back, I get to listen, I get to watch our fellows demonstrate all that we have been training them for. So here is our logistics for today. Each group is going to have to present for 20 minutes uninterrupted. And then after their presentation, we are going to take questions from the audience. The questions, feel free to text your question, chat your question, direct them to me or to any member of our staff, and we'll take those questions live, unedited, uninterrupted, directly with the fellows interacting with you. And then I just want to also begin, before I kick this up, I want to thank each and every one of our fellows who has endured, some intensity. These are smart people that have different degrees, but you have been exposed to a program like no other. You have felt a discomfort. You have listened to me telling you this is no, this is zero. But today you got to show the world the beauty of what you have learned. I would like to thank all the members of faculty, Dr. Susan Ekejiba for your support, Bram Magnus Olivers, who is our IT outreach, everything class administrator, and our Dr. Zubi, who is running the entire program and gatekeeping and ensuring that everybody who has desire to join this program is rigorously interviewed before they can join the program. And finally, also want to thank Dr. CJ Eboluche, who has been helping us here, organizing our programming and every other one. So this is it. This is it. This is our team here. You can see me here. You can see Dr. Susan. You can see Dr. Zubi. You can see CJ. And you can see Brown Magnus. Each and every one of us bring diverse experience, diverse educational preparation, diverse practices in public health, diverse public service. So we are bringing to the all the fellows that we train the opportunity to learn from us, to learn directly from what we have learned in our own practice. So we'll continue to admit people. Next slide, please. All right, so we're going to begin with an introduction of all our fellows. Please follow the guideline that we have here. Each fellow is going to introduce themselves, tell us a little bit about themselves, and then we'll move on to the next fellow. So let's begin with Abdul Hakim Jimo. Dr. Jimo, introduce yourself to the audience.
I'm Abdul Hakim Jimo. I'm a medical doctor, MD in the USA. I'm joining from New York City. Thank you very much.
All right, next is Fiona Mahugu. Fiona is a registered nurse. Come on, Fiona.
Good morning, everyone. I am Fiona Mahugu. I am a registered nurse and nurse consultant. I'm based in California, USA. Thank you.
All right, next is Dr. Bowen Jimonique. All right, next we have Ibtisam Kayid. Ibtisam, come on, go.
Hi, everybody. I am Ibtisam Kayid, and I'm completing my master's in public health in the next week. And I'm joining you from Michigan, United States. Thank you.
Congratulations on your graduation. The next we have Bernard Cynthia Olebube, all the way from Nigeria. Come on, Cynthia.
Hi, everyone. I'm Bernard Cynthia Olebube, a registered nurse from Nigeria.
Excellent, excellent. Next one is Stephanie Glassman. Come on, Stephanie, tell us who you are.
I'm Stephanie Glassman and Director of Strategic Partnership and Outreach. I am joining from Bradenton, Florida.
The beautiful Sunshine State of Florida. And next we have Eben Uwayeme Ekoyeder. Eben, come on, tell us where you're joining from and who you are.
Hello, everyone. Good evening. My name is Ekman Koyata. I'm Nigeria with MPH. Thank you.
All right, and the next is Somya Nala. Somya, come on. She's a pharmacist by training. Somya. You there, Somya? All right, moving on. Next one is Daniel Mami. Daniel is a data scientist by training. Come on, Daniel, tell us who you are. Moving on. Next one is Clint White. Clint, you tell us. Clint has the fun place. He actually lives somewhere that is a little bit fun and exciting. Clint, come on, introduce yourself.
I'm Clint White. I'm reaching you from Okinawa, Japan, and I'm working on my master's in public health from New York University.
Come on, Clint, you make us jealous. And next is Patson Ndolovu. Patson, come on, let us know who you are.
Hello, everyone. My name is Patson Ndlovu, with an MPH, seated in the city of Bulawayo, Zimbabwe.
That is very close to Harare. Very good. Thank you so much, Patson, for and the last but no least, the list is Dr. Mazie Jafari. Mazie, come on, tell us who you are.
Hello, everyone. My name is Marzia Jafari. I'm a physician based in the Washington, D.C., United States, and I'm a clinical director for this project.
Thank you so much. You know, beautiful fellows, wonderful from all backgrounds, different parts of the world, you know, different experiences. I have gotten to know you people closely, some of your quirks, and you have also dealt with all my quirks. But this is, I can tell you, this is an incredible cohort. Every cohort of this program gets unique, gets incredibly you know, creative and innovative. So I'm so excited to have all of you joining from all parts of the world. Next slide, please.
Daniel is here.
Come on, Daniel. Come on, Daniel. Introduce yourself, Daniel. I've been waiting for you.
I just wanted to. Hello, everybody. You know, I was playing with, you know, my laptop because my laptop is old, and then I tried to, you know, put on, you know, my tablet. I don't know what is wrong, but hello, guys.
Look, Daniel, don't tell me you need GoFundMe. We are not going to fundraise for you. No way. We're not doing that. And I saw that the list is actually missing our own Darren Podomo. How can we miss Darren, who is taking us to Don? Come on, Darren, we can do that. Come on.
Sorry, yeah, I was going to say I didn't see myself on there. I'm Darian Perdomo. I'm an MPH student as well. I'll be finishing soon in the spring, and I'm joining from North Carolina in the U.S.
Thank you so much, Darren. Look, Darren, it's up to you if you want to do GoFundMe for Daniel, but I'm not going to do that. You know, Darren, come on. You
We'll
can
put
use your
something together.
old, we just want to see your face. You can use your old laptop, your old tablet, it's okay.
Yeah, I'm here now. I'm here. I'm sorry.
Very good. Very good. All right. Am I missing anybody? No? Okay, good. So, this is our team. I'm always excited. This is our team. The team here, you have worked with us all through this period. You have gotten to know us. We're almost like a family, building together. And I just wanted to tell you all how proud, how grateful, how honored that all of us feel to have been part of your professional development. Wherever you see yourself in your career, always remember GHEP is a home for you, is a family for you who will always reach out to you. I just, it's always the day that I feel nostalgic because I feel like we have all worked together for 3 months and then suddenly we are seeing, the end of it, in one way. So please do not be strangers. If you see our email, join. Next year, we are going to launch for the first time an online virtual public health conference, a small one. So we are going to invite all of you to come present, to come share where you are, to come tell us where you are, what you are doing. So I just want to make sure that you all know that the door is open for you. We might actually be reaching out to some of you to become mentors as the cohort begins to grow. So I talked about the programs that we are going to present today. The first one we're going to take is PUMSER, Project Una Melura Sante, Sickle Cell Disease Prevention in the Democratic Republic of Congo. And then after that, we're going to have Faith Bridge Autism Screening Initiative, FASI, which is going to talk about autism and developmental disabilities here in the United States. And then we always save the best for the last. We're going to have Community Action for Youth Resilience, CARE, which is going to be talking about drug abuse prevention intervention in Nigeria, Africa's most populous country. All right. I just want to point out, Brown, that this program is being live broadcast on YouTube. You can ask friends, you can send out the links, you can ask them to join us, but we love them to join us here. Please, I want to wrap this up by thanking all the guests, all family members, all friends, all significant others that have supported each of these fellows in their journey over these last 3 months. I know it has been very inconveniencing. And many of them are waking up middle of the night to join programs. Many of them are leaving work, to come in the evening. Many of them are joining the program late from work. But each and every one of them couldn't have done it without all your support. So I want to really thank all of you for your support of each of our fellows, and we are hoping that you will be proud of the product that they will provide today. All right, Brown, next slide. This slide is not moving, Brown. Come on. All right, so this is us. Please follow us on LinkedIn. If you use Facebook, follow us on Facebook. Facebook.com myghep. If you are on X or formerly Twitter, the same thing. myghep, and we have a YouTube channel that we call GHEP TV. I hope all of you are following us on LinkedIn. Remember what we talked about. To be a professional in public health, LinkedIn has to be the home where you establish yourself as a professional. Keep LinkedIn handy. Tweet, Facebook, but post on LinkedIn and keep following us for more information. Next slide. All right, now it's time to hand it over to the sickle cell disease group, who are going to talk to us about their program to prevent sickle cell disease in the Democratic Republic of the Congo. DRC, over to you now, team. Come on.
Can you guys see the screen? Right, okay. Hello, everybody. My name is Daniel Mami, and our topic for discussion today is Project Melinio Sante, PUMSA. It's all about sickle cell prevention in the Democratic Republic of Congo. Our team consists of 4 members: Daniel Mami, which is the project director in USA.
And I am Marzia Jafari, clinical director.
And I'm Patson Ndlovu, director monitoring and evaluation.
Hello, I am Stephanie Glassman, based in the United States and Director of Strategic Partnership and Outreach.
So by the end of this session, participants should be able to understand sickle cell disease in the Democratic Republic of Congo, including basic genetics, prevention, and reducing community stigma. And secondly, promote access to screening and timely follow-up for individuals and families at risk. And then finally, support effective treatment and strengthening local healthcare capacity for sustainable long-term sickle cell care. And I'll pass this to my colleague, Marzia.
Okay, so first, let's start with the problem we are facing. Sickle cell disease is one of the most common inherited disorders in sub-Saharan Africa, and the DRC is heavily affected. A mutation in the beta globin gene leads to hemoglobin S, causing red blood cells to sickle, which results in the chronic anemia, painful crisis, and long-term organ damage. In the DRC, about 1.35% of newborns are born with sickle cell disease, and nearly 20% of the population carries the trait. Tragically, 50 to 90% of children with sickle cell disease don't survive past the age of 5, mostly due to preventable complications. And families often struggle with care costing over $1,000 per patient per year, far beyond what most households can afford. PUMAs aim to address exactly these issues by understanding the current care landscapes, identifying the gaps, and proposing strategies that can truly make a difference. Next slide, please. PUMAs focuses on Kinshasa, and more specifically the Chango district. Chango is a large home to over 2.5 million people with an almost equal number of men and women. The literacy rate is around 80% and average schooling is about 10 years. These demographics matter because improving education, awareness, and screening in a community of this size can have a major public health impact. Next slide, please. The goal of PUMAs is straightforward: to reduce preventable illness and health linked to the sickle cell disease among newborns, children, and families in the DRC. Next slide, please. To achieve that goal, we are focusing on 3 main objectives. Number 1, strengthening community education and awareness, so families better understand sickle cell disease and feel empowered, not stigmatized. Number 2, increasing newborn and adult screening, because early detection is a life-saving. Number 3, improving follow-up, treatment adherence, reducing stigma, and building healthcare provider capacity so patients get consistent, high-quality care. Next slide, please. Here's what PUMAs means for the people we aim to serve. For communities, awareness campaigns can reduce stigma and increase trust in the health system. For newborns and children, early screening means fewer complications and fewer deaths in the first years of life. For health facilities, Providers gain skills in screening and managing sickle cell disease, helping build a more sustainable system. And for families, education, counseling, and better care help reduce financial and emotional strain. Next slide, please. For sure, our work isn't possible without a strong partnership. We are collaborating with the Ministry of Health, Kinshasa University Hospital, and primary health centers. Academic partners like the Faculty of Medicine support research and evaluation. Internationally, we work with the WHO, UNICEF, and the Sickle Cell Disease Africa Network, who provide technical guidance and capacity building. And at the community level, organizations such as Foundation Congo, Assistance, women's groups, youth networks, churches, traditional leaders, and community health workers all play essential roles. Next slide, please. Other key stakeholders include patients and families themselves, the healthcare workers who provide frontline care, and policymakers who guide national strategy. Donors and the philanthropic organizations help support programs financially. Schools are important partners for raising awareness among young people, and media outlets help amplify public health messages. Passing off to my colleague Patson. Thank you.
Okay, thank you. So the project PUMSA, as you can see, this project is a 2-year project that we anticipate that it will run from March 2026 to around February 2028. So for us to achieve the goal that my colleague has just shared, we have got our implementation plan where we have got tasks or actions that we need to do. First of all, of course, getting the funding, and then also doing the baseline assessment, as well as project design. So this will be the first thing to do. Then there is development of relevant IC material and training materials. And we also intend to conduct project inception meetings with the key people. And this is going to start next year in 2026. We also intend to conduct training of trainers for key people, those who will be training others, those who will be capacitating the community health workers, for example. Then after having the trainers will then conduct the training of the healthcare providers, as well as the community health workers, like the village health workers who are within the Kinshasa, the district of Changu. Then we also now implement the project that is conducting awareness campaigns, as well as mass screening and referrals. And then we will develop policy and guidelines that will disseminate within the school so that they inform the community. During the implementation process, we'll obviously conduct routine support visits together with monitoring visits and support. Then towards the end of the project, that is 2027, at the end to early 2028, we'll then conduct an end-line evaluation just to see how the impact of the project. We'll then thereafter do a project closure and also hand over to the local authority of that district so that they could continue with the program if possible. Next slide. So now, in terms of our theory of change, we were saying, why is it that how are we going to, or how do we assume this project is going to have an impact? My colleague shared the problem statement before to say there is high prevalence of sickle cell disease, and sickle cell trait amongst newborn in the Democratic Republic of Congo, in particular in Kinshasa, Changu district. So we are also, this is also worsened, of course, by, lack of awareness of the sickle cell disease, and also poor skills of the healthcare workers in terms of screening, in terms of treatment, in terms of, in terms of counseling. So these are the problems. Therefore, the goal of PUMSA is to reduce, or at the end of the day, to see this program, reducing high prevalence of morbidity as well as mortality that is associated with the sickle cell disease in the district or in the community of Kinshasa, Changu district in Democratic Republic of Congo. So we intend, of course, to conduct the activities that we think, if we have these inputs, like if we have the budget, if we have the rightful people to implement the activities, and also if we have the supplies and all the equipment that we need to implement this project, we will be able to conduct the activities like development of all the pamphlets, IEC material for distribution. We'll be able to conduct or carry the mass screening at community level, as well as all the trainings that we talked about. We will conduct those ones. Thereafter, we intend to see the outputs that can be quantified. Those are immediate outputs to say, after implementing the activities, we need to have the IC material printed. We have a number of people, reached with the information, as well as, the healthcare workers trained. So all these activities, they've got quantified outputs. So once we deliver those outputs, we hope that we will see some changes. We will see some outcomes. The short-term outcomes immediately will include increased awareness and also increased knowledge on sickle cell disease amongst the community of Chandu. And then we also have, a better skills by the healthcare workers in terms of service delivery. Then in the medium term, we want to see, or we hope to see, an increased number of people getting tested, getting screened and referred, for further management. We also hope to see improved supportive behavior from the community, where we see people, having the behavior that is not judgmental, people living well with those living with sickle cell disease. And long term, of course, when people, they get screened early, they get treatment, we hope that we will have low incidences of morbidity and mortality that are related to sickle cell disease in that community. Then that becomes the impact of the project, and that will directly address the goal of the project of PUMSA. Right? So next slide. And in terms of timeline, the first 6 months, of course, it's more like a planning phase where we'll engage the stakeholders, where we'll also, measure what is there, the baseline, and also where we conduct the trainings so that we then kickstart our implementation. And then 7 to 18 months thereabout, this is where the bulk of the project activities are going to be implemented. That is awareness campaigns, training of the community health workers, as well as, healthcare providers from the health facilities that are within the district. And then we will also conduct the massive mass screening, as well as referrals and mentorship, also including engaging the communities. Then the last 3 months, it's when we're closing down the shop, where we're consolidating our activities, as well as, handing over the ownership of the project to the local community, and as well as conducting the end-line evaluation and sharing the findings. Right? So with that, I will hand over to my colleague, Daniel.
So our outcome for this project is, so our short-term outcome is from 0 months to 12 months, which is exactly 1 year. So we aim to increase community awareness about the sickle cell disease and its inheritance pattern. And we also want to inform more families receiving information on prevention, screening, and early care. And then also we want to communicate with community health workers and church volunteers train them to provide basic educations and referrals. And then for our immediate outcome, which is going to be 12 months to 24 months, which is exactly 2 years. So our aim is to achieve at least 30% increase in public awareness of sickle cell disease. And we also aim to achieve at least 25% in the increased diagnosis through community-based screening. And we also want to achieve at least 10% improvement in timely referrals to partner health. And then our long-term outcome, since we already think about, we cannot just think about, the project for the period of 2 years. So we think about the long-term outcome, which is going to be beyond the 24 months. So we aim to, within that 24 months, we aim to reduce the complications and preventable death linked to sickle cell disease. And we also partner with local capacity for sickle cell screening, counseling, and data reporting will be strengthening. And then finally, a sustainable community center model that can be expanded to other regions like villages and towns of the Democratic Republic of Congo. So for our evaluation plan, we asked this question, what we will measure. So for the purpose of our evaluation, we want to track the progress. We want to improve implementation, and we want to document the impact of our program. And then for our evaluation approach, we use a mixed method, which combine quantitative. Quantitative is like, for example, survey, and then qualitative, it's like, focus group and interviews. Then we want to process the evaluation to monitor how these activities are delivered, and also how the outcome evaluation to measure changes in awareness, screening, and referrals. So our key indicators were the number of people reached through the awareness activities, the number of individuals we screen and diagnose, the number of providers and volunteers we trained, changes in knowledge, attitude, and health-seeking behavior in the community. And then we also asked this question, how we will measure it. So our data collection tool, we use the baseline survey on community knowledge and attitude. And we also use screening logs and facility records to track testing, diagnosis, and referrals. And we also put into consideration the focus group discussions and interviews we receive from community members and healthcare workers. In terms of our data management and analysis, so local health workers and volunteers collect data, which were supervised by the Ministry of Health and the Kinshasa University Hospital. These data were entered into a secure digital database and review monthly. And quarterly dashboard, for example, Excel or the DHIS2, which is a District Health Information System 2, to visualize the trend and guide adjustments. And then for the responsibility led by the Director of Monitoring and Evaluation, which is Patson, in collaboration with local partners like, this non-governmental organization, churches, mosques, clinics, health centers, etc., to ensure data quality and use of results for decision-making, like implementations of new policies. And then for our staffing plan, so for the project leadership, the project director, which oversees the provision of the overall leadership, he coordinates partners and ensures activities stay on schedule and within the $200,000 budget. And for our clinical director, she oversees all clinical components, including screening protocols, diagnosis, and genetic counseling materials like flyers and banners. And for our partnership and outreach, the Director of Strategic Partnership and Outreach, she managed relationship with the Ministry of Health, faith-based network like for the mosques and the church, and international partners such as WHO. She also coordinates awareness campaign and community engagement, something sort like, a middleman. So for the monitoring and evaluation, the Director of Monitoring and Evaluation, he is responsible for designing the data collection tools like survey, leading monitoring and evaluation efforts, and also preparing quarterly and final reports. So in terms of our team coordination, the core team meets monthly so that we can review the progress of the project and also address future challenges or current challenges so that we can adjust to strategies. This staffing structure will ensure us a clear role, accountability, and strong coordination across all project components. And we also decide to have a country coordinator, which he is gonna base in the Democratic Republic of Congo. And one of our criteria, our eligible criteria, he should speak fluent French because the DRC speak French. And he is responsible in managing and coordinating all project activities within the Democratic Republic of Congo. And now I'll pass this next slide to my colleague, Stephanie.
Our $200,000 budget ensures we have the essential resources to run this community-based sickle cell program effectively. Most of the funds support personnel, training, and screening supplies so we can provide reliable care. We also included costs for community outreach, social media, and education to reach families throughout the area. Transportation and monitoring tools help the program operate smoothly in all communities. Overall, this budget is focused, practical, and aligned with improving sickle cell outcomes in the DRC. Please turn to the next slide. In conclusion, this program marks an important step toward improving early detection, prevention, and long-term care for sickle cell disease in the community. By training local health workers and strengthening outreach, we are building sustainable, community-driven support. Partnerships with leaders, clinics, and policymakers will help ensure long-term stability, while community involvement remains central to success. With strong resources and collaboration, this initiative can significantly reduce complications and improve quality of life for those affected in the Democratic Republic of Congo. Thanks for listening, and we welcome any questions.
Very good. Thank you so much. This is great. Please let us give them, let us show them some love using our reaction button. Let us show them some love. I'm showing here. Let's give them a round of applause. Good work. Good work. And I do have some questions that are coming in here. So the first question is, you said medication is available for sickle cell. So why are you emphasizing on genotypic testing? Who wants to take that? So you said there is a medication which is hydroxyurea, and then the person is saying, why are you now emphasizing genotype testing? In other words, if you have medication for it, why are you doing genotyping?
I can take these questions because we emphasize genotyping testing because we cannot prevent or treat the sickle cell when it happened. But because it's inherited, if we do the genotype testing, we know that which person is the carrier and which person has a trait, because there is a difference. If two people with the trait that is not symptomatic married to each other, they can have the carrier child. But if two person that they are carrier and doesn't show any symptoms, they got married, they can have the 20% chance of having a child with the sickle cell disease. So genotype testing provide information about the gene situation in the one person, because sickle cell disease doesn't show, if in the case of the carrier and the trait, doesn't show any symptoms. The only symptoms can be seen in the diseased person, not in the carrier person. That's so important, genotyping test.
Thank you.
Yeah, thank you. Maybe just to add there, in other ways, we're saying genotyping is for purposes of prevention, while the medication is for treatment. Thank you.
Next question is saying, where will this program be implemented? Why is everyone based in the United States?
So in terms of the project leadership, the project leadership is based in the United States, and the people we're gonna hire are gonna be based in the Democratic Republic of Congo. That's why we have the country director who is gonna be responsible to hire like the community health workers and all other people or stakeholders involved.
And also based in the being based in the United States, we can collaborate with the international resources, the WHO, the UNICEF. We can collaborate closely with this organization as well and provide the sources for the local people.
Next question. It says, you are going to be collecting a lot of data from the people in DRC. Who will own this data?
So,
Okay.
okay, yeah, you can go.
All right. So this data is going to be collected in the DRC. We're going to have a local team based in the DRC. Those are the people who will be responsible to collect, all the data in the local language, and we will obviously have means to ensure that we secure the data that we will be collecting. And because we will be having an antenna office in the Democratic Republic of Congo, and also we will be regularly visiting the project site to make sure that everything is in order. So in terms of how it's going to be kept, it will be in collaboration with the key project officers as well as the local people in DRC. Thank you.
So another question, it says, many people think that sickle cell disease is demonic. What do you say?
So this is where we would make sure that we hammer in when we're saying we're conducting awareness campaign. We will be correcting all those myths and misconceptions to say this is a hereditary, it's not demonic, it's not anything that is man-made. So we will focus more in terms of busting those myths and misconceptions during our awareness campaigns. Thank you.
Another question. Does this project team think that sickle cell can be eliminated in Africa or in DRC?
It can be reduced, but not totally eliminated.
Yeah, so through doing those genotypes and identifying those people with the traits, so that then you know in terms of marriage, in terms of who should, to reduce having an active disease, that is the sickle cell disease itself. So we can also reduce the impact of it. But some people can live with the trait without then making it worse by having an offspring that is got the sickle cell disease.
I think that's all the direct messages that I got. Okay, one more here. Do you have any guidelines on how parents can have discussions around genotype regarding sickle cell with their children?
So for now, we don't have the guide, but within this project, this is where we intend to develop these guidelines based on our baseline surveys to hear what is it that the community knows, what is it that the community do not know. So we'll then design those guidelines to say, okay, we need to put the basic facts, the correct facts about sickle cell disease. And then we need to guide the parents. What is it that they need to explain, how they need to explain to their children, because at that age they need simplified explanations. So we'll have the guidelines after conducting our baseline and also having some stakeholder engagements that the community leaders and all, just to understand what is happening within the district of Uchandu. Thank you.
All right. Let's open it up now. Anyone here, raise your hand or open the mic and ask your question. Anybody from the group, anybody from the program, any questions? So I'm going to do a quick poll, not scientific here, but everyone, I want you to use your chat to tell me how implementable, how shovel ready do you think this project is? 1 is least, 5 is the highest, 1 the least and 5 the highest. What do you think that how prepared, how shovel ready do you think this program is ready for implementation? On a score of 1 to 5, 1 being least, 5 being the highest. Okay, 4.5, Abdul Hakim.
And ourselves, should we also vote?
Yes.
Okay.
4.8. Shovel ready is a concept we use to determine to what extent a project is ready to be implemented. If you were to give the project to somebody who is not part of the team, can they successfully implement this program without having to go back and forth? 4.5, 5, 4.5, 4.5. That's this is biased. Maybe I should have used a different poll. Okay, 4.5, 4.8. All right. Okay, it has a very high implementation index right there. 4.8, 4.5 too. Okay. Good. Any more last minute questions? Otherwise, please join me. Let us thank a group, PUMSA group, for an excellent presentation. Nice job, guys. Nice work. All right. Now we need to have all the fellows on camera. Remember, we need to now switch to the autism spectrum disorder group, to talk to us about the program they have designed for Dunn in North Carolina, the United States of America. Over to you now, group.
Okay, thank you. Here, let me put it up here. Okay, you can see everything okay? Cool. All right, good afternoon, everyone. Thank you for being here. We're excited today to present the FaithBridge Autism Screening Initiative, or FAUSI, a program designed specifically for Dunn, North Carolina. presenting this on behalf of Global Health and Education Projects. Here we see our global team behind FOSSI. What makes our group effective is that while we span different backgrounds and lived experiences, we share one core mission together, and that's expanding equitable access to early childhood services. The team consists of myself, Darian Perdomo, MPH. I'm joining from North Carolina, and also Salmia Nala, who's an MPH joining from the United States. She's currently traveling right now, and she's our Director of Outreach and Communications.
I'm Clint White. I'm also working on my MPH. I'm joining you from Okinawa, Japan, and I'm the Director of Technology and Platforms Development.
Hello, everyone. I'm Ikme Koyata. I'm Director of Strategic Partnerships, and I'm joining from Nigeria.
Okay, so today we're going to have three main objectives in the presentation that we're going to cover. First, we'll get grounded in the overall purpose of FOSSI as a program, why the initiative exists, and the gap it's working to fill in the Dunn community. Next, we'll break down the major program strategies that shape how the initiative actually operates on the ground. And finally, we'll walk through the key goals and activities of the program so you get a full picture of how everything's connecting together, what we're doing while we're doing it, and how we expect it to create impact in the community for the families there. So you're probably all, first question you're thinking is, what is FOSSI? Before we get deeper into the details, we're going to ground everyone in what the program is. The FaithBridge Autism Screening Initiative, it's a faith-based community center program designed to increase early autism screening and connect families to the care that they need. The idea is pretty simple. Churches and other trusted community spaces in Dunn can become accessible points where families can learn about developmental milestones, get their young children screened, and if needed, receive support navigating the referral process. By meeting families where they already are, especially in a rural town with limited specialist access, FOSSI can help close the gap between concern and care and makes early identification both approachable and equitable. So to begin, it's important to better understand the problem we're trying to address here. Autism disorder, it affects about 1 in 31 children nationally, and North Carolina reports even higher prevalence. Dunn, located in Harnett County, is part of a region facing some of the most persistent gaps in early developmental services. During our needs assessment, a few issues became immediately clear. First, Dunn has limited access to developmental specialists, no local developmental pediatricians, neurologists, or BCBA certified providers. Families often routinely travel 30 to 60 miles for evaluations out of town, which is a major barrier for caregivers that are working hourly jobs or managing limited transportation. Second, we have rural infrastructure issues that compound the problem even further. Several census tracts in Dunn have low broadband internet access, which makes telehealth developmental evaluations that are more common post-COVID even less reliable. Schools and child care centers also lack special education staffing, which makes it difficult to support children with developmental concerns. And then high poverty rates and limited public transit access add layers of challenge, particularly for early intervention access. All these factors together, they lead to delayed screening, delayed diagnosis, and delayed intervention. And that's the gap that FOSSI is attempting to close here. So our objectives here translate the problem into short-term measurable actions. They focus on several areas. First, we aim to screen 400 children ages 0 to 8 using validated tools like the Ages and Stages Questionnaire, or ASQ3, the Communication and Symbolic Behavior Scales Developmental Profile Infant Toddler Checklist, or CSBS-DP-ITC, and then the Social Responsiveness Scale, or SRS-2, and then we'll use these to deliver results within a week and ensure every flagged child receives a referral. And then also we'll train 450 stakeholders, including providers, educators, childcare workers, and faith leaders. Importantly, we also include specialist-led training from developmental pediatricians and autism experts so local practitioners can build long-term competence. And then we'll have navigation assistance that will ensure families understand results, complete referrals, and overcome barriers like paperwork, scheduling, and transportation. And then finally, we'll intentionally prioritize outreach to low-income, rural, and minority household groups. These are groups that are most affected by delayed diagnosis of autism. So here, our implementation plan has 3 major components. First, we'll be having community screening events that occur monthly at churches, schools, clinics, and community centers. Because the program timeline is limited to 24 months, we've selected screening tools that don't require prolonged follow-up beyond a 2-year period. We're using, as mentioned, the CSBS DP Infant Toddler Checklist. That's going to be for ages 6 to 24 months. And then the Ages and Stages Questionnaire, ASQ3, that will be used for ages 2 to 5 years old, 5.5 years old. And then the second edition Social Responsiveness Scale, or SRS2, that will be for ages 5.5 to 8 years old. And all 3 of these tools, they're validated, brief, easy to administer, and they're highly sensitive to early developmental concerns. And even better, they can be administered by non-clinicians as well as parents, since they screen based on observations in natural settings. Next, we'll have provider and parent workshops that will be interactive. This is where faith leaders, childcare staff, and parents can practice identifying milestones, spot red flags, and have sensitive conversations with families. This is important because evidence tells us that hands-on training dramatically improves confidence and early identification of autism. And then a key part of these workshops, and a key component of these workshops, will be our specialist mentorship. Developmental pediatricians, child neurologists, and autism specialists will help train dumb-based providers. These specialists will come from institutions like the University of North Carolina's Treatment and Education of Autistic and Communication Handicapped Children, or also known as TEACH Autism Program, and the UNC School of Medicine's Developmental and Behavioral Pediatrics Division, and Duke University Health System's Developmental and Child Neurology departments, who we all plan to engage for potential pro bono or in-kind consultation and training. Their involvement is important because it will help boost accuracy and long-term sustainability of the program. And then finally, we'll have referral navigation services as mentioned. Since Dunn lacks a dedicated developmental diagnostic center, families often become stuck in the complicated referral process. Our navigation team will help with the forms, the scheduling, transportation coordination, and follow-up to ensure families don't fall through the cracks here. And then here we see our theory of change diagram. It shows how our inputs lead to long-term impact. We begin with the funding, trained staff, screening tools, partnerships, and volunteers. These resources then support activities like faith leader trainings, mobile screenings, caregiver workshops, and referral navigation. From these activities then comes measurable outputs: children screened, adults trained, screening kits distributed, and quarterly events held. These outputs then lead to intermediate outcomes like increased screening uptake, stronger referral pathways, and faith communities incorporating ASD education into their ministries. And ultimately, with all this, the impact is a reduction in a diagnostic delay and the creation of a sustainable community-led early detection network in Dunn. The mission statement at the bottom reflects the heart of the project, and that's building something that the community can maintain long after the grant ends. And now I'll pass along to Clint to go over our timeline.
Okay, so our timeline, our program unfolds in structured phases. The first 3 months is our launch and capacity building. This is where we hire staff, contract development specialists, purchase outreach materials, we finalize the partnerships, and we train our screeners on all assessment tools. Months 4 through 18 is where we represent the full implementation phase. This includes the monthly mobile screenings, delivering same-week results, providing navigation support, and hosting recurring parent and provider workshops. This phase also includes mentorship from the specialists that we mentioned before. This reinforces what we learned from the grant research. Hands-on coaching is key for sustainability in these rural areas like Dunn. And then also referral navigation during this time frame is also central, helping families complete paperwork, schedule their appointments, and actually access evaluations, which is where breakdowns usually occur in these rural communities. Months 19 through 22, this is where we focus on the evaluation and the data analysis. We review screenings and referral data. We go over the pre and post workshop outcomes, the family satisfaction surveys. We also conduct provider feedback assessments with those specialists, and we prepare dashboards and reports to measure progress towards those SMART goals that we made. And then the last few months, 23 through 24, is where we focus on the sustainability of the project and handoff to the community. This is where we train remaining community members and partners to maintain the screening procedures independently. We transfer the tools to them, materials, and referral protocols to the churches, schools, and clinics, so the model continues after the funding ends. Finally, we share evaluation findings with the local leaders and policymakers, and we present a sustainability roadmap outlining how Dunn can continue screening long-term. Next slide, please. Back to you, Darian.
Thank you. So here we'll see our outcomes. We've organized them across the short, intermediate, and finally long-term phase. Short-term outcomes include screening the 400 children, training 450 adults, like we mentioned, returning the results within a week, and ensuring 100% of flagged children receive referrals. We also expect the local providers to complete the mentioned specialist-led training, improving screening accuracy. Intermediate outcomes include more families completing diagnostic evaluations, increased caregiver confidence navigating the referral process, providers becoming more comfortable with the ASQ3, CSBS, DPITC, and the SRS2 screening forms, and stronger partnerships across churches, schools, and clinics. And then finally, the long-term outcomes beyond the 24-month grant period, that'll include aiming for earlier ASD identification ages, sustained community screening capacity, reduced rural and minority disparities, and then faster access to early intervention. These are all grounded in evidence that shows that equipping communities with early detection tools has lasting impact long after programs end. And I'll pass it back to Clint here for our evaluation plan.
Okay, so our evaluation plan, this is how we're going to measure the success of our program. It's comprehensive and it aligns with best practices in monitoring and assessment. We're going to track outcomes metrics like screenings completed, how many screenings we completed, hopefully up to that 400 mark that we put in our goals. How many referrals are made, the referral completions, participant knowledge gains through the pre and post tests for these screeners themselves. We use tools. We're going to use tools such as digital referral tracking systems, workshop surveys, and the family satisfaction assessments. We also evaluate productivity through staff logs, the event counts, and follow-up appointments. Finally, we are going to monitor capacity development. That's how many practitioners were trained, how many organizations adopt screening procedures, and how interagency referral pathways strengthen over time. Together, these measures allow us to tell a complete story of program effectiveness and guide continuous quality improvement. And then I'll pass it on to Ekben.
Okay. Our staffing plan for FASI is simple. The right people in the right roles to deliver strong community-centered impact. At the top, our program director provides oversight, managing timeline, staff, budget, and evaluation. Our program coordinator keeps daily operations running, from logistics to screening and outreach. Our screening specialists handle assessments and mobile screening across communities. The outreach and faith liaison builds trusted relationships with churches and supports culturally grounded workshops. Our data and evaluation assistant tracks our progress and keeps our dashboards accurate. And our faith champions and volunteer bring the work to life through registration, navigation, and awareness efforts. Now, a key addition is our contracted developmental specialists, brought in periodically for training, mentorship, and case guidance. These partners often come from institutions like UNC Teach, Duke's Health System, or UNC's behavioral and developmental programs, many of whom offer pro bono consultation or outreach days. Together, this team forms a coordinated workforce equipped to deliver early screening and accessible support for every family we reach. Next slide, please. Now here's a snapshot of how we allocate the 200,000 budget for FASI. Most funding goes towards personnel, reflecting the importance of staffing in early childhood programs, but we've also reserved funding for materials, workshops, community navigation, technology, and evaluation tools. One point to highlight from the proposal is that our budget emphasizes lean, sustainable spending by leveraging volunteers, faith-based infrastructure, and pro bono or in-kind specialist support. We stretch resources further while still delivering high-impact services. I'm going to hand it over to Clint. Next slide.
All right, so to close, FASI matters because families in rural North Carolina face some of the steepest barriers to early ASD detection in the country. By expanding screening access, strengthening faith-based partnerships, and supporting caregivers with culturally responsive navigation, we can help ensure families in Dung get the support they deserve. Our initiative not only addresses today's disparities, but builds long-term community-owned capacity for early identification and referral. Thank you for your time, and we look forward to any questions you may have.
Very good. Thank you so much, the FASI team, for an excellent presentation. Please, let's just show them some love using our react button. Keep them coming. Thank you so much. Excellent, excellent. So questions, I have a couple of questions that people messaged me here. Questions. Let's begin with the group. Any questions from the group or from individuals who join in online, unmute and ask questions or text your questions? All right, so the first question I have here is, this is faith-based, right? So when you refer to faith-based, are you referring to only churches, or are you also referring to non-churches like mosques, synagogues, and so on?
So in this particular community, it's primarily focusing on churches, since a lot of people know this region of the United States in the South, there's a region called the Bible Belt. It's located smack dab in the middle of the Bible Belt, and they have actually quite a high number of Pentecostal churches in particular in that community. So, but the goal is that you could use the structure for this program in other settings too, like if it's in a particularly Muslim Islamic area or any other faith, you could partner with that religious institution and work together to create a program and increase the screening. But in particular, churches in this community.
Thank you. That's excellent. Very good. So I have another question here. It says, autism is a hot potato issue in the United States right now. I think everyone here is going to agree. But the question is the high prevalence of autism really that we have more people or is it as a result of improved screening? What does the team think?
So in many areas of the United States, yes, it is driven by increased screening access over the years. Like particularly in certain states, like I know like New Jersey, California are a couple states in particular where they've identified that the higher incidence is likely due to that. I think that applies overall for the United States. But it doesn't necessarily mean that it's like more people are like developing it. It's just that we're identifying it more as we increase the access over time, as we decrease the stigma surrounding it with education.
Any other thing to add? All right. The other one I have is, can you speak about the difference between autism spectrum disorders and attention deficit hyperactive disorder? Sometimes people are not sure what is what. And it doesn't have to be the group, any other member of the group. We have a lot of physicians here. You can help us too.
So mainly with autism and attention deficit hyperactivity disorder, I think those are more identified based on the type of behavioral patterns that are going on. Like with autism, there's certain behaviors like it's kind of like repetitive phrasing a lot of the time with autism, and usually sensory overload with autism patients, loud sounds, certain textures, whereas that may not apply necessarily for someone with attention deficit hyperactivity disorder. So it's mainly identified based on what the behavioral patterns are between the two.
Excellent. Thank you. Anything else to add?
The other thing is going to be the age of the diseases in the ADHD is early in the earliest school years, and the children have the difficulty in sitting still, following instruction. But in autism, it's going to be happen before age 3.
Thank you so much. Oh, there's another question here about data. It says that you guys are going to be the team is going to be collecting very sensitive data about people's children. How are you going to keep this data safe and confidential? What are you using to collect this data? Good question.
So like we mentioned, we'll be using those dashboards, and we'll be ensuring that we'll be using secure platforms for those, and they'll only be shared with the patients and their family. It won't be any kind of open access software or anything like that. It'll be something secure and private.
Yeah, I think it's important to point out here that any data you are collecting on patient information or personally identifiable information should use a HIPAA compliant data collection tool, the Health Insurance Portability and Accountability Act, HIPAA. So it's very, very important whether you are collecting in DRC or you're collecting here in the US or in Nigeria. It's always very important to ensure that the data system, the infrastructure you're using is HIPAA compliant and that it has been certified to be able to collect PII.
Oh,
Very good.
Can I also add to it that only authorized staff and the caregivers will have access to individual results.
Great. Yeah. So that's one, but the system that you're using to collect it, right, has to be HIPAA compliant.
Yes.
It has to be certified that it's HIPAA compliant. And then individuals that will use it, like you said, we have to have the training. Otherwise, what happens is if the system is not HIPAA compliant, security is not up to par, is not certified to be HIPAA compliant, then people can easily hack in and see people's information. Excellent. Thank you so much, the FASI team. This is excellent. Very good. Okay, moving on to our beautiful last group, the group on drug abuse prevention in Nigeria. Over to you. Please keep the questions coming. Direct message me, chat me. You can text me, or you can mute yourself and ask your questions. All right, go for it.
You're muted.
Good afternoon, everyone. Once again, we are Group 1, and we're going to be presenting on Project CARE. CARE is a community action, is a program which is designated to solve some problem in Yaba, Lagos, Nigeria. It's a community action for youth resilience, a drug abuse intervention project in Yaba, Lagos, Nigeria. Let's meet our team. I am Abdulakim Jimoh, an MD in the United States. I'm also joining from New York, and I'm also the Director of Communication and Outreach.
And I'm Eftesam Kayed. I'm the Director of Monitoring and Evaluations, and I'm joining from the United States of America.
Ms. Jaminek is not here.
Hi, I'm Oligbe Bernard, Director of Research, and I'm joining from Nigeria.
I am Fiona Mahugu, based in California. I am Director of Partnership and Stakeholders.
Okay, thank you. So the learning objective. At the end of this presentation, we want our viewer and audience to be able to understand community-driven strategies that can significantly reduce the incidence of drug use in Yaba community, Lagos, Nigeria, by up to 20%. At the same time, we also want them to be well informed about educational campaigns that can increase the awareness about the dangers of drug abuse by up to 40% in Yaba locality. And lastly, we want them to understand the need to foster the resilience in youth by providing supportive networks and rehabilitative measures that can empower them in terms of resource availability and ability to make positive life choices. Now, the problem statement, why Yaba community and why Nigeria? Why do we decide to undertake this project in Nigeria and why Yaba community? Let us look at the national prevalence. Over 14.4 million Nigerians between the ages of 15 and 64 were documented to abuse drugs. And over $1 billion in annual financial burden in the form of healthcare costs and loss of productivity has been well documented also in Nigeria. Now, looking back to Yaba, Yaba in Lagos is a multi-ethnic, a multilingual area in the mainland local government area of Lagos, with Yoruba language as the predominant language. In 2024-25, it was estimated that Yaba has a lifetime prevalence of 81.1% of substance use among adolescents. Yaba was also estimated to have a population of around 438,000 in 2021, and is a well-known technological hub of Lagos. And also around Yaba, it bears academic institutions like Yaba College of Technology, University of Lagos, and many more, hospitals, field-based organizations, and many more in that particular region. The mobility trend in Yaba includes lung diseases, HIV, hepatitis, depression, psychosis, which is information given by the National Institute of Drug Abuse in 2020. It was estimated that the average cost of treating substance use disorder in 2020 was between 135,000 naira and 146,000 naira in most hospitals, including Yaba Neuropsychiatric Center in Lagos to also look at that. Okay. Now, factors such as what? Unemployment, poverty, educational status, and peer pressure are documented causes of drug abuse in this particular region. Commonly abused drugs include alcohol, tobacco, and cannabis. We are looking at what marijuana, which some people will call weed, pot. They have different names in different parts of the world, are the most commonly abused drugs in this particular part of the world. Now, my colleague, which should be discussing the goals and implementation, she had a recorded video to describe that.
Java is a vibrant, culturally rich community in this region. However, as my colleague Jennifer mentioned, its youths are disproportionately affected by drug use and dependency. Major drivers are lack of awareness, poor social support, and youth unemployment, which leaves many young people vulnerable and most susceptible to peer pressure.
Can Abdul Hakim, can we pause that and move that forward, please?
Yes.
Can you continue presenting?
Okay. So the program goal. So the CARE program aims at decreasing the prevalence of drug abuse in youth through community awareness, increased resilience, and economic empowerment. Now, what is the implementation plan? The implementation plan is a multifaceted one, and it's also hands-on intervention procedure. We want to make sure that we undertake informative outreach workshop that engage the community on drug abuse prevention using the screening, brief intervention, referral, treatment and treatment model, which we call SBIRT. And also we want to make sure that we're able to educate community, youth, through proper education, through support group, empower local residents of Yaba. Collaborating with leaders and health workers with the aim of fostering a supportive environment for recovery and resilience. We also want to make sure that we're able to collaborate and tap into resources from the local NGOs. And some of the NGOs that were identified, where some of them were National Institute of Medical Research in that region, Action Health Incorporated in that region, Child and Adolescent Mental Health Center in Oshodi, which is a nearby region very close to Yaba. Other things, intervention that can also be done is to improve education, increasing awareness, multi-layered education, school and youth center, life skills sessions, community and faith-based engagement, digital outreach, social media, and WhatsApp. These are forms of awareness that can be done to also engage with the youth in this particular region. School and youth center programs, interactive learning about drug risk, so which is a form of what education program to educate youth in schools, decision-making and coping skills, if you have anyone that is affected, peer discussion and scenario-based activities. Community and faith-based engagement, town halls, church and mosque, you have to go there and go there and increase promotional talk on drug abuse and educate them about the causes, the manifestations, and how it can be managed, and also refer them for treatment. Street theater and community outreach, video programs in English, Yoruba, and Pidgin. Digital and mass media outreach, we can also try to engage a lot of social media campaign, to LinkedIn, TikTok, Facebook, and many other. Short educational videos, WhatsApp broadcast messaging, all of this can be used to increase awareness in this particular region. And community economic empowerment is very important because we know that one of the major causes is unemployment. So we want to be able to link the youth with those organizations based in the Yaba community that can also assist them in securing jobs. Some of the jobs could be vocational jobs, and these are some of the lists of the organizations that we have: NBC, LSETF, Semicolon Africa, VHLA, YST Foundation, YEF Nigeria, and AppSmart Unique Foundation. So these are skill training workshops and mentorship and employment pathways, which can also be a source of empowerment for the youth in this particular region. So this is the same slide, just enforcing the previous slide on those organizations that are available in the Yaba community. They can provide empowerment in terms of securing employment and vocational training for youth in this particular region. Over to Ms. Bernard for the theory of change.
The theory of change, here we have the resources, which are the people we're working with, their activities, the output, the outcome, and the impact we are going to the end of the program. Number one in the list, we have the trained health, education, and social resources personnel. Their activities is to integrate drug education into community, schools, and youth program. The next is the community-based organization and NGOs. Their activities is train teachers, healthcare workers, and community leaders on prevention and early intervention. We have the educational institution, the youth group, and the local businesses. Their activities in this program is to establish youth-friendly counseling, rehabilitation center, and economic opportunities. We have the media and the community and the communication platform. They are going to be collaborating in their activities is collaborating with media to promote positive behavioral change and change messages. And the last on the list is
advocate to law enforcement bodies and increase activities and regulatory activities. And the activities to appeal to law enforcement agencies to improve vigilance. Probably this slide is not very clear on our end.
Keep moving. Keep moving, Abdul Hakim, please.
Ms. Bernard. Okay, the project timeline. So we have phase, we have the planning phase, which is between January and April 2025. And the activities that we done will include gathering community input, setting goals, and forming partnership with local organizations, community mobilization, which is going to be between April to September 2025. Outreach activities will include, we have outreach activities, which is going to include engagement of local leaders and workshop to engage the community. The various meetings also involved. Implementation, which is going to be between October to December 2025, and also launch educational workshop and support group providing resources and services to address drug abuse while involving community members in the process. Monitoring and evaluation to January 2026 to May 2026, in which we're able to get feedback, surveys, and community engagement to ensure effective and adapt strategies as necessary. And the final report will be between June 2026 to December 2026. The summary of the outcome and successes will be shared. Insights with stakeholders and community members will also be shared. We highlight our achievements, and also we want to see areas that will be subject to future improvement. Over now to Ms. Ibtisam.
For our outcomes, we hope to reduce drug use incidence by 20%. This is for our short-term outcomes. Also increasing awareness of drug dangers by 40%, and improving access to counseling, referrals, and support groups. For our long-term outcomes, we hope to lower overall drug use prevalence in the Yaba community, strengthen community resilience to limit access to drugs, and expand youth empowerment activities that prevent future drug use. Next slide, please. For what are our evaluation strategies? We will start off with surveys. We'll use surveys to assess program effectiveness and identify improvement areas. We'll be using pre and post surveys that will measure change over time, and KAP questionnaires that will help us understand shifts in knowledge, attitudes, and behaviors. Also, we could be conducting interviews. We'll conduct in-depth interviews with community members to capture detailed qualitative insights. And lastly, doing focus groups. We'll hold focus groups to discuss program impact and gather diverse perspectives from participants. Next slide, please. I will hand it over to my colleague.
So we're going to talk about our staffing plan. We are planning to have a group of 4 people, and that is the project coordinator, the community mobilizers and community health workers, skilled workers, and counselors. So the project coordinator is going to oversee the implementation, ensuring that activities are aligned with the community needs and objectives. And they're also going to be the liaison between the stakeholders and the team members. We have community mobilizers and health workers who will engage with the local residents, raising awareness about drug abuse issues and promoting program activities through workshops, meetings, and outreach initiatives, and also being the referral for specific treatments. We have skilled workers, and this include the doctors, nurses, psychiatrists, psychologists. They will be responsible for their diagnosis and treatments and also coordinating of care in the regional health centers. And last but not least, we have counselors, and this include the addiction and substance abuse counselors and also the peer support counselors. So these ones will provide emotional support services to individuals and families affected by drug abuse, offering guidance, therapy, and also resources to promote recovery and well-being in the community. Next slide. Let's talk about the budget. So we are going to work, estimated budget is $200,000, and this budget shows the funds needed to carry out this project. It includes the cost of the staff, supplies, and program activities. The budget supports the goal of the proposal and explains how the funds will be managed responsibly. So we have the personnel, which should include the project coordinators, skilled workers, counselors, and others, roughly around 10 members, and this will be $90,000. Training and capacity building, which includes workshops, peer educators, community workers, roughly $45,000. Community outreach, so this includes awareness, media campaigns, social media, printing all the flyers, $20,000. Treatment and rehabilitation, which includes therapy sessions and all the medical supplies, $10,000. Monitoring and evaluation tools, so this includes all the data analysis, which is data collection, assessments, and field visits, $15,000. And indirect costs, which include all the overhead costs, which is 10%, and that is $20,000. So everything totaling to $200,000. Next slide. So in conclusion, Project K is an initiative aimed at addressing drug abuse in the Aba community at Lagos State in Nigeria by increasing awareness and improving prevention and support in the community. Proposing grant funding for a region with high prevalence can advance awareness and expand screening, prevention, support, and treatment initiatives, marking a constructive step towards improvement. So our project seeks to create a safer and more resilient community that can withstand and reduce the impact of drug abuse. That is the end of the presentation. We welcome any questions.
Very good. That was good. Project Care. So Fiona, how do you pronounce this? Is it Care or Care? How? What is the name?
Care.
Care. Oh, okay. Care. Okay. Project Care in Yaba, Lagos, Nigeria. Excellent work. Excellent work. Let's show them some love. Congratulations. This is really good. This is good. This is good. All right. I have a couple of questions, that are coming in here. But before we do that, let us we all listened and asked questions of the FACIT team. You remember the team that talked about autism spectrum disorder screening, identification in Dunn in North Carolina? We did not do the implementation readiness scoring for that project. They thought I was going to forget, but I'm always remembering. I forget things, but I still remind myself. So let's do. So the implementation readiness score is our ability to evaluate to what extent a particular proposed project is shovel ready, can be implemented. So if you were to give it a reasonably qualified public health practitioner, program manager, or project management official, can they reasonably implement that program without calling Darian or calling them every 5 minutes to say, what do you mean by this? What do you mean by this? What do you mean by this? So we score between 1 and 5, 1 being the least and 5 being the highest implementation readiness score. So can you please score for me? Abdul Hakim, you've been nice, 4.5 for Farsi. Okay, that's good. What else? Who else? Farsi. We are scoring Farsi. Okay, 4.5. Who else? Every other person is 4.8 Mazia. Oh my God, 4.550 Sam. 4.5 Stephanie. Wow, okay. Daniel, 4.9, nearly perfect. Cynthia, 4.5. 4.5. Patson. Be careful what you're scoring because you might be asked to come and implement the program. So if you say that it's ready, then you can come back and ask questions. Very good, but that's good. That's good. 4.5 and 4.9, which is very, very high implementation readiness score. Now turning over to the project care, right? The community action for youth resilience, drug abuse prevention in Lagos, Nigeria. What is the implementation readiness score for that? 1 being the least and 5 being the most. Everybody can score, including the team. 4.9. Ibtisam, what, for care, project care, what is the implementation score? If we gave this project to you to go implement, Cynthia 4.8, Mazia 4.5, Abdul Hakim 4.5, Clint 4.5, Stephanie 4.5, Abimbola 4.5, Eben 4.5, Darren 4.6. Okay, so Patson 4.4, Fiona Mahugu 4.8. Very good. Okay. All right. So we have questions, and some of the questions I'm going to throw them open to all the 3 groups. Number 1. So we're going to begin with the care group, right? What is the leading drug that is used in Yaba, Lagos? Which one is the leading drug? Because I see you mentioned alcohol, you mentioned
alcohol
cannabis.
is the leading one. Alcohol is the leading one.
Okay, so are you considering alcohol a drug within Western context or within African context?
In the scientific context. So alcohol is one of, because the project is about psychoactive substances. And psychoactive substances are substances that can influence the body physiology in a particular way. And those substances are divided into 4 to 5 categories. We have those drugs that are stimulants, which are some of them. We have those drugs that are depressants. Alcohol fall under the category of depressants. We have hallucinogenic drugs. We also have the psychotic drugs, antipsychotic drugs. So these are the general categories. So it falls into one of the major drugs category.
All right. So how successful do you think you're going to be? Edmund is here, Patson is here to create a substance use disorder program focused on alcohol drinking in Lagos, Nigeria. How successful do you think you will be?
Well, we will try as much as possible to bring down the prevalence, and we address all the necessary factors that might actually promote the consumption of alcohol. The underlying causes, we try as much as possible to talk about that. And also all the routes we have highlighted, we're going to go through that to community involvement, community health promotion activities, both at the level of the schools, academic institutions, faith-based organization. We do all of that to make sure but most importantly, the education, and also trying to address the underlying cause. We can do that to some extent, but not completely to a large extent, because we want to empower them to make sure that some of them have employment, because this is one of the causes. We want to make sure that most of them are busy. They have other things to do at all the time. We want to try to talk against peer pressure, and also increase level of education in terms of what the community is experiencing.
So just to clarify here,
yes.
Even here in the US, there is a very big contextual social discussion around alcohol, right? Yes, alcohol is the #1 substance, psychoactive substance that is most used, but alcohol is also more socially acceptable than other psychoactive substances. So I think the point I'm trying to make here is for you to be aware of the fact that if you go to a place where alcohol drinking is socially acceptable, which is globally,
Yes.
right? You may have some challenges really providing a program unless you are targeting individuals for whom their alcohol drinking has become problematic, clinically problematic.
Yes.
Otherwise, you're gonna have problem with recruiting people. Nobody's gonna join. So people are gonna say, so this program from US, you are trying to say we shouldn't drink alcohol, and then suddenly you have nobody joining your program. So that's what I'm trying to push there.
Yes.
So you identified a number of NGOs that you're gonna work with in Nigeria. Is there anyone that you have made contact with?
Not really. Not really, but I think I should be able to contact them, and I should be able to get a lot of valuable information from them if I was to make contacts right away.
Okay. One question I'm going to ask you, and then every group is going to take that question. That is, what is one top challenge that you are going to have in implementing this program in Yaba, Lagos?
One of the top challenges, I think, is trying to, one of the things we said was the planning phase. We give a little time so that we can get to know the community properly. So we might not be able to find volunteers, like get it into the program. It might be difficult to identify targets. So it might take us a little time to establish a very reliable network for which we're able to get most of the people that are going to get into the program, people that will be screened, people that will be educated. So it can take a little time for us to be able to get acquainted to the community and execute the plan as we aimed.
Any other thing to add, Fiona? Members of the CARE team, any other thing to add?
So I think just the stigma surrounding drug abuse in these African countries, especially Nigeria, people are still afraid to come out and come up like they need help. So I think just tackling the stigma around drug abuse is also one of the challenges that we're able to face still.
Cynthia? Cynthia? All right, moving on. Yeah, go ahead. Yes, Cynthia.
The only challenge that we are going to have, like Fiona said, it's the affected people coming out. Here in Nigeria, they have busy days, and for them, they don't have issue with the problem we're talking about. It takes, like, I don't know how to put it, but it takes the ones that need help to speak about it and come out for the program. They just see it over there as a normal thing. Let's just drink. Without drink, we cannot move on with our daily life. So if they don't see it as a problem, they are not going to come out. That's just the only challenge we're going to face.
That is a key, that is a major problem that organizations face, is that you get ready, you prepare to implement a program in a country, you have all this data to demonstrate that this is a problem, but the people for whom you made this program are looking at you like, something is wrong with this guy. This guy is saying there's a problem. There is no problem. So being able to conceptualize a problem that is truly a problem within the people, within the community, is very critical for you, especially for alcohol, which is a socially acceptable practice. So, okay, moving on to FASI group. What are some of the major challenges that you are going to experience in installing FASI in Dunn, North Carolina? We know that this is the Bible Belt of the United States. Everything is in the Bible. What are some of the challenges?
So yeah, like you mentioned, it is the Bible Belt. So that's probably going to be one of the largest ones that we have things to acknowledge. It's because faith-based communities, they may view developmental differences through a spiritual lens rather than a medical one. So they can make them hesitant to accept clinical diagnoses. They might have a stigma around it because in close-knit communities like this, some families may worry that a diagnosis will label their child or lead to judgment outside of the community. And autism can often be misunderstood as a deficit rather than a difference, and which can also increase reluctance. So that's going to be one of our biggest ones, I think. Just ingratiating ourselves with the faith-based community in the area.
Darren?
Yes, I agree with everything Clint said. Another hurdle that I could see coming up is, we're talking about bringing in the developmental specialists. That could be a very costly part of the budget. It could be very expensive to contract those. If we're unable to get the pro bono support from an institution when we reach out. So that could cause us to have to take funding from other areas of the budget, like in advertising events and everything, and organizing the events. We may have to organize fewer events because we're spending more on bringing in outside specialists. So that's something that I think would be a hurdle as well.
Edmund, do you think your team will be credible to bring this program to Don?
Very well, yes. Following the team will be credible very well, following the program that we designed or we structured out. We will do well.
How will you be credible? You are not from this community, right? They don't know you. You show up with this program. How are you going to be credible? They do not know you. So I want practical, action-laden things. How are you going to build credibility in a community where nobody knows 3 or 4 of you?
First of all, we have our program director who's going to be mostly on ground, and not just that. We're going to use partnerships, especially with the liaison officer, the outreach and liaison officer. We're going to make use of all of them. We're going to get into the community through the faith-based, the churches, and also the schools as well. So we're going to get into them first, get to know them, get to meet them, and then know how we're going to implement the project.
How are you going to do that?
It's first of all, the whole idea of bringing a program into any system, you don't just come into the system, the community heads, the community leaders. So it's a process. So after informing the community heads, the community leaders, the faith-based leaders, they're going to have stakeholders meetings, sessions, and then before moving into the community proper. So we having our team set up as our staffing outreach liaison officer who's going to be from the community to help us liaise and get into the system, into the community.
All right. So there is the concept of using key opinion leaders. Whenever you go to a community, you must identify the key opinion leaders. These are not political heads. These are individuals who live in the community that has high credibility within the community. You have to, if you are Christians, you get a point, right? You're not going to introduce a program if you are not a Christian, if you don't ascribe to the faith. The pastors are not going to take you as credible. So you need to identify key opinion leaders, and those will be individuals, or they could be organizations that many people gravitate to. You have to build trust. People can see you when you're actually not serious, when you are not genuine. People can see through you and know that you're actually not genuine. I'm saying this because I know I have implemented programs. So you need, if you are working in a Bible Beth, you need to be a Christian, or you need to find someone who's a Christian, or you need to find someone who is a key opinion leader, who could be a man or a woman leader, the wife of the pastor or the pastor of the church. Then they will become the gatekeepers that you are going to use in order to get to the community. So otherwise, you're going to do all the program you like, it's not going to work. You're going to call attention, nobody's going to show up. All right, moving on to the sickle cell disease group. What are some of the leading challenges you are going to face in implementing this program in the DRC?
I think it's gonna be the language barrier, because most of us speak English, and then in DRC they speak French, so it's gonna be the language barrier.
Language, that's a key one. What else?
The other reason, the other challenge would be the cultural beliefs and the stigma that it's going to be the people believe that the sickle cell is a spiritual cause, has a spiritual cause. So that can reduce the community participation. That's why we are using the churches, because churches are a trusted place for people, specifically in the area that we are implementing our program, and we can build the trust through the churches that this is the medical situation and it can be prevented.
Patson, who are the key holders of the families in DRC? Is it the mothers or is it the fathers? Who do you go to in order to get to their family? Who is it, the mother or is it the fathers?
So it's a patriarchal family setup. So it's the husbands, the fathers, they're the ones who say everything. Similarly, the key opinion leaders are the traditional leaders in those areas. Yeah.
To install a program in a place like DRC, part of your engagement will be identifying nonprofits that are working in that area. You know, even when you are in the US before you go, those are the people you communicate with, you start discussing with. And then they can align to tell you things to do. If you come in to see the traditional rulers, they'll be the people that give you idea who to meet, you know, who to talk to. And so there is an art in it. There is a science. You can propose all you like, but when the rubber meets the road is when you are on the ground and you are trying to engage and implement. So you can see across the 3 programs, regardless of where you are implementing, whether you are implementing in the US or in DRC or in DRC in the East, or you are implementing in Africa in the West, challenges are identical. And we talked about the core values for public health practitioners: genuineness, right? You know, or honesty, fidelity, ensuring that the people can trust you, that they can trust that what you are doing, you do sincerely believe in it. If you do not believe in it, people are going to see through it. You know, there are some Bible verses that you can use to document the fact that, you know, human beings trying to take care of themselves is actually there in the Bible. You just need to be that person that understands, or need to know who you can leverage to be able to help you do that work. All right, so this is great. It's been an honor again listening to these 3 amazing programs. We may be calling upon you to do short summaries of the program, one short summary that we are going to post on our website, and that will be an opportunity for people to contact you. If we have anybody who wants us to implement this program, please stay on the standby. We are going to reach out to you and see whether we can pilot these programs. So before I wrap up, I just want to give a couple people, individuals, opportunity to share their feedback, share their remarks, share how they feel today about the program before we wrap up. Anybody? I'm not going to mention anybody now. What has the journey been like? Yes, Dr. Abdul.
Well, this is a very wonderful experience for me. I learned a lot from every angle, apart from the presentation. So even the coursework itself complemented everything I learned in EWU. I'm going to be finishing in January. I'm going to be finishing my MPH program in January, but everything I learned in this program complemented everything I've done completely. And I've gained a lot of information, a lot of confidence in being able to initiate a lot of a program myself. If I need help, I know where to get the help. So this is a really good and productive investment and also experience for me. I can't thank you enough, Dr. Romy and everybody at GHEP. Thank you very much. I'm very grateful.
Thank you so much, Doctor. That's very, very helpful. Remember, always remember, if there is something you remember all the acronyms we use in program development, in outreach, right? All talk and no action. So when people are challenging you, you will know why they are challenging you. You are the ambassadors of this program, and we are going to look up to you to creating programs that will change lives. Any other comment?
Yeah, I have something to say. So I had a great time. This course was awesome. I like that I was able to implement some practical skills that I learned in my MPH, and that I don't really get to use in my actual career because I'm not anything really related public health. So I'm glad that I got this experience, and thank you for the opportunity.
You are very brave. You are the earliest. You're always operating in the next day, and your commitment is really contagious. I really commend you for no excuses. You were always there, just like Abdul Hakim. Any other comment? Feedback? Yes,
Okay.
Cynthia. Come on, Cynthia.
Yeah, I must say this program is a very nice one, and I learned a whole lot. I got to work with people I don't know. Do you understand? And I'm sorry I froze this night. I just came back from work, so I was very, very tired. But I really, really enjoyed the program, and I want to thank you especially to all my colleagues, who worked with me about this whole program. Thank you.
Very good. The power of the network. Now, regardless of where you are, you have friends and colleagues across the world. You can always email them. You can always reach out to them because you've been part of the work that they are doing. You can ask them questions. You can collaborate with them, and you can network with them. Like I said, we'll reach out at any time, to reach out to you, to ask for your expertise. Keep your eyes out for the call for our inaugural public health conference. It's going to be virtual for 2026. We invite you to come present. The intersection between policy, program, and implementation, so that people can get the opportunities to share
My
as
mic
well.
is on.
All right. Yes, Eben, did you want to talk?
Yes. I want to say a very big thank you to the entire GHEP team for organizing such an impactful program, public PH360 program. And I would say that it has been really strengthening. It has really helped me. It has shaped me. It's a whole lot. It's a whole lot. And like I said in my write-up, I said it's a robust program. And thank you so much for everything. And it was good to meet everyone. And also a very big thank you to my team, my group members. They did great. I appreciate each and every one of them. Thank you, sir.
Thank you, Eben. If this were to be easy, we will have a full house. Sometimes when people come to the program and we tell them they're going to join every Friday, they say, this is not for me. And that is understandable. But I hope you guys are living with an investment in your careers that you are always going to remember. I hope you can always hear me ringing PDA, right? You always hear me ringing that when you are designing programs, but also understanding that each of you have the skills now to make money. You can create programs, you know how to create programs, you have sample programs you've created, you can make money with those. Individuals can ask you, can you help us form an NGO? That is money, that is consulting. Remember, you never walk to a doctor's office, even if they're your friend, and they treat you free of charge. So public health practitioners should not be doing things free of charge. People shouldn't be coming to you to say, oh, I'm trying to create an NGO, can you help me? The doctor will say, yeah, you sign in, they take your insurance, and then he or she will see you. So the same thing for you. If people come to you, want to create a program, want to create an NGO, of course, intake them. and charge them money for your skill, for your expertise, for your time. That's what I preach. If you finish this program, you should be able to make money from this program, what you have learned. All right. Brown, any concluding remarks before I want to thank our guests who actually stayed with us all through the program. Thank you so much. I hope you have seen the work that your friends did. I hope that you guys can consider joining the program if you are eligible. And I hope you all continue to support our fellows as they continue to make progress with their careers. All right. On that note, I want to congratulate all of you again, once again. And I say congratulations. Have a wonderful holiday. Have a wonderful new year. And I'm looking forward to completing all the paperwork for all of you that need to go out between now and Monday. Congratulations and thank you so much.
Thank you.
Thank you.
Thank you so much.
Thank you.
Thank you very much.
Thank you,
Have a
everyone.
great day.
Thank you, bye everyone.
Thank you, guys.